Hello, everyone, and welcome. Today's webinar is focused on aging, heat illnesses, and chronic disease management and mobility during natural disasters. My name is Dr. Sherry Weiser, and I co-founded and co-direct the UC Center for Climate Health and Equity, along with Dr. Ariane Teherani. The mission of our center is to harness the expertise and leadership of the health sector to drive ambitious climate action for health and health action for the climate. And the center is based at UCSF, but we span all 10 campuses and 5 health systems with over 100 affiliated faculty. Today's webinar, which is co-sponsored by the UCSF Academic Senate Committee on Sustainability, is the third and last webinar of our spring series on the health impacts of climate change across one's lifespan. So today we'll be specifically focusing on aging in relation to heat illnesses and chronic disease management, as well as mobility during natural disasters. To remind people, over the last few months, we also focused on children's unique vulnerability to climate change and on adult reproductive and occupational health. And both of these previous webinars are now up on our YouTube channel, and we welcome you to listen to them. It's now my absolute pleasure to introduce today's moderator and a close colleague, Dr. Tariq Ben-Marnia. Dr. Ben-Marnia is co-chair for research as part of our UC Center for Climate Health and Equity. He's also an environmental epidemiologist at the University of California, San Diego's Scripps Institute of Oceanography, where he leads the Climate Change Epidemiology Lab. He finished his PhD in epidemiology jointly from the University of Montreal, so my hometown, as well as in Paris Sud, and is a postdoctoral and completed his postdoctoral position at McGill University with the Institute for Health and Social Policy. His work is in combining epidemiologic methods with environmental and econometric models with a specific focus on health policies and environmental justice in California and globally. And welcome, Tariq. I will turn it over to you.
Thank you. Thank you so much, Sherry. And thank you for your introduction. And thank you, everybody, for being here today to hear our featured speakers. So today the scope will be extremely important because we're going to really talk about why extreme heat is a huge public health issue in the context of climate change, and why specifically some subgroups of the population, especially among the elderly, are particularly vulnerable, emphasizing the role of pre-existing mental health issues and also some kind of structural and housing conditions. So this is extremely important because, as you probably know, extreme heat is by far the biggest killer among all of the environmental issues in the US and globally. But that's a silent and sneaky killer. And trying to understand which population are particularly vulnerable and at risk, and what can we do to make the most vulnerable communities as resilient as possible in this issue is extremely important. So that's why the presentation that we are going to be listening to today are going to be extremely important. So now it's my pleasure to introduce the 3 speakers that we have today, and I will start by Dr. Andrea Sheridan. And so our first speaker, Dr. Andrea Sheridan, is a geriatric psychiatrist and professor of clinical psychiatry and neurology at the University of California, San Francisco at UCSF. She completed her residency at Baylor College of Medicine, in Houston, Texas, followed by a geriatric psychiatry fellowship at UCLA, University of California, Los Angeles. Her clinical and research interests include the psychiatric manifestations of neurodegenerative diseases. And prior to joining UCSF in 2015, Dr. Sheridan was on a faculty at UC Davis School of Medicine, where she also served as an associate dean for students' wellness. In June 2019, Dr. Sheridan co-founded the Climate Change and Mental Health Task Force at UCSF, which is now merged with the UC Center for Climate Health and Equity. So thank you, Dr. Sheridan, for being here today. And our second speaker would be Mr. Eddie Alm, who has been an environmental justice attorney and non-profit worker for over 15 years. And his graphic memoir, Advocate, was just recently published by Penguin Random House. While working as the executive director of Brightline Defense, an environmental justice nonprofit, he has been inducted into the state of California Clean Energy Hall of Fame for his work in equity and clean energy. In addition to his work, he has served on 3 commissions related to environmental policymaking, president of the San Francisco Environmental Commission, as well as the Metropolitan Transportation Commission, the MTC, and the Bay Conservation of Development Commission. He's a self-taught artist who has been recognized as a cartoonist in residence by the Charles and Schulz Museum in Santa Rosa, which is pretty cool. So thank you so much, Eddie, for being here today with us. And our last speaker and third speaker is Mrs. Carol Correa, who is a Brightline Air Quality Coordinator and Communications Lead. So through her work at Brightline, Mrs. Correa provides free real-time air quality information, resources, and trainings to the underserved community of Oakland and on the east of the Bay of San Francisco and the south of San Francisco. Mrs. Correa also serves as a community expert as part of the California Air Resource Board, the CARB, Community Engagement Group. And before joining Brightline, Mrs. Correa also organized rent relief canvassing campaign in LA and received a bachelor's from Brown University in environmental studies and Hispanic studies, which is very relevant. So now I will let Dr. Sheridan discuss the connections between mental health among model adults in the context of extreme heat, and then Mr. Ahn and Mrs. Correa are going to introduce their presentation. So thank you again for joining us today, and I really look forward for the three exciting presentations. Thank you so much.
Thank you. Thank you so much for that introduction. And it's my pleasure to be here together with Eddie and Carol. And congratulations on your book, Eddie. I can't wait to see. I would like to thank the organizers, in particular, Dr. Tehrani and Dr. Weiser, for inviting me. And it's my pleasure to talk about one of the topics that are very important to me, obviously, as a geriatric psychiatrist, but also hopefully this is of interest to all of us here. And we will talk about not just extreme heat, but just very briefly touch on a few other aspects of climate-related aspects. So for disclosures, I have no conflicts of interest, no funding. We talked about the task force that has merged with the UC Center for Climate Health and Equity. We're very proud. And I do want to say just very briefly that some content may be difficult for people who have experienced directly extreme climate events or vicariously. And then also just to ask, we have a few manuscripts in progress, so please do not disseminate the slides without my permission. So our job today is to talk about, understand age-specific factors that contribute to the mental health impacts of climate change, specifically in older adults. Of course, there's a lot more in other age groups, but we're focusing on older adults. And we're going to briefly touch upon natural disasters, extreme heat, and air pollution. We're going to discuss the climate-related psychiatric symptoms. And also, I want to spend some time, just a little bit of time, on social and ecological determinants of health. First, I want to take a moment to share with you why I do this work. So working here at UCSF, obviously, always wonderful weather year-round. But then we started having wildfires. And in 2017, actually, a lot of our patients were affected by the wildfires, either directly having to be evacuated or indirectly through the smoke and the consequences of wildfires. So here's what one of my patients who has Parkinson's disease said. I woke up at 2 a.m. She said, I'm lucky I have Parkinson's because I don't sleep. Saw an orange glow on the hills. I got my binoculars and realized the orange glow was fire that was quickly approaching. I woke my husband up. We got in the car and fled. It was very scary. I could feel the heat of the fire through the car door. This was one of my patients who lived in Santa Rosa at the time, and they were lucky. They actually evacuated. They were able to escape, and they got moved twice. First went to a temporary shelter in Santa Rosa, and then moved with family for about a month until they could safely return to their home. She was lucky. The fire spared their house. The house across the street burned. But they weren't. These are the people who died in the Camp Fire in Northern California in Butte County in November 2018. 85% of the victims were older adults, over 60 years old. So that's why we do this work, because we need to learn about the consequences of natural disasters and try to prevent those, and of course, hopefully do some mitigation work. So I'm going to share with you just very briefly aspects related to wildfires. This is just to prime you. You probably recognize this, one of the most iconic, most photographed areas in California. This is Emerald Bay in Lake Tahoe. And I actually took this photo on vacation with my family. And this is what Emerald Bay looked during Caldor Fire in 2021. And if you see this smoke, you start thinking asthma exacerbation, cardiorespiratory disease exacerbation, increased risk of stroke. All of these are more common in older adults, my patient population. But then there are floods and hurricanes. And again, just seeing these images after in the aftermath of Hurricane Harvey that affected Houston in 2017. And you can imagine why this is more difficult for my patients, for older adults. You get the idea. So why are older adults at higher risk during natural disasters, heat waves, or also during poor air quality times? Because of limited mobility. As you can see in the images I've shown, medical neurological diseases cause limited mobility. They may not hear well or see well, sensory impairment, so they may not understand how to get out when natural disasters come. They may have cognitive deficits, again, more common in the older age, but not always. Psychiatric illness, again, all ages, but maybe more so for some of my patients. Linguistic isolation, they may not speak the language. They may have moved to the United States later on in their life and live with adult children or in diasporas where they are isolated, or limited social support, living alone. All of this contribute to not being able to get out of harm's way. We'll talk a little bit more about floods and hurricanes and extreme heat in a moment, but I just wanted to share with you one brief statistics from actually UCSD, our colleagues at San Diego and Stanford. They calculated the excess deaths due to poor air quality in the month where you may remember August through September 2020, when we had the orange skies because of the smoke in the atmosphere that blocked the sunlight. And they calculated that 1,200 to 1,300 older adults died that would not have died otherwise due to poor air quality. And this is actually a photo I took at noon from the Parnassus Hill at UCSF. How about during or after hurricanes? There can be drowning, injuries, disruption of medical care. And again, think that this is harder for my patients, for older adults with mobility impairments. They may not get to dialysis on time. They may not have the portable oxygen, or they may have appliances that are powered by obviously power outlets, and they don't have that, and they don't have backup generators, exacerbation of chronic diseases, exposure to toxic chemicals, or unsafe homes when they return after flooding. These are images from Puerto Rico, thanks to some of my colleagues who were there after Hurricane Maria in 2017. And again, this is what the infrastructure looks like. People can't get to the hospitals or to the clinics to get the care that they need. How about mental health? Quite a bit of research, especially after Sandy and after Katrina in New Orleans. So Sandy on the East Coast in 2012, 14% of adults, 14% increase in depression symptoms reported by adults over 60 years old in affected areas, and then also significantly higher utilization, in particular by the oldest old, people who are 85 years old or older, immediately after Sandy. They needed dialysis, they were dehydrated, they had electrolyte imbalances, they needed their prescriptions to be refilled, and then some had lost their homes. True for people after Hurricane Katrina of all ages. But then also here's an inequity that I wanted to share with you. Older adults who had post-traumatic stress symptoms and high blood pressure had a higher risk of cardiovascular events, new cardiovascular events, such as heart attacks, cardiac death, congestive heart failure exacerbations 1 to 2 years after Katrina. This was true for Black Americans, but not for whites. During heat waves, we will talk a little bit more with Eddie and Caro, but older adults are more susceptible to dehydration. They don't sweat as well as younger adults. There's lower total body water, decreased thirst sensation. They don't know when they're supposed to drink to stay hydrated. The kidney function, the cardiac function slow down, and so does the blood flow to the skin and extremities, which all these are the mechanisms through which we cool off when we experience heat waves, extreme heat. And then also older adults may restrict fluids because they take fluid pills, diuretics, and they don't want to go use the restroom every single hour. So they may not drink water or fluids. And then medications that we'll talk about in a moment. Lots of medications, but one thing I learned as I started to look into this literature, psychiatric medications, things we prescribe often, can increase the risk of heat stroke. So I started talking to my patients about this, actually people taking antipsychotics, a lot of anticholinergic medications that we prescribe, antihistamines like Benadryl, people take for sleep, antidepressants, all of those can affect sweating and thermal regulation and increase the risk of heat strokes. And then there are also other medical medications prescribed for medical diseases. The list is long. Furthermore, people who have dementia are at higher risk of utilizing emergency rooms, so ending up in the emergency room or being admitted to the hospital for medical reasons, most common reasons being falls, weakness, and altered mental status. The risk of dementia-related hospitalization increased, as you can see here in this study, by almost 5% for every degree Celsius. This is a European or Canadian study where they measure in degrees Celsius. But then living in communities with lower green space surface also increase the risk of admissions for Alzheimer's disease-related reasons. And then for psychiatric hospitalizations, not medical hospitalizations, there was a study that looked at all the US Medicare recipients that, and there were about 1 million hospitalizations for schizophrenia, bipolar disorder, and depression. And they noted that these were increased when there was increased temperature. The findings were true in the colder season, though. This is a very interesting study from the UK, where they looked at the death registry over this decade that you see depicted here. And they found that for patients with dementia, psychosis, and who use substances such as alcohol and drugs, again, 5% increased risk of death for each additional degree Celsius above the average temperature for that time of the year. And then another study looked at nursing home residents, and they found that increased risk of death during heat waves, 1.6 higher risk of death. Also, same study from Page et al. From the UK looked at people taking hypnotics, anxiolytics, so medications we commonly prescribe for anxiety or for sleep, and antipsychotics, and they again had higher risk of death, as I mentioned, and this association remained significant after removing the patients with substance misuse diagnosis. So it wasn't because they were drinking or using drugs and being out in the street and unprotected. It was actually associated with taking medications. I should say, though, all the epidemiological studies that I will talk about also, they're associations, they're not causal associations. We don't know that caused it. But we know that they found these associations in large numbers of people. In this table, we put together, basically reviewed the literature for you, specifically for older adults, and put together psychiatric symptoms. And as you can see, anxiety, depression, PTSD, post-traumatic stress symptoms, psychosis, such as delusions and hallucinations, sleep disturbances, universal, substance use, suicidality, and cognitive impairment, all with each one of those factors that we show here: extreme heat, hurricanes and floods, wildfires, drought, and air pollution. I do want to spend a minute, if I may, on cognitive impairment. Bidirectional, I think it's a bidirectional correlation with natural disasters or abrupt relocation. So basically, if you take someone with pre-existing cognitive deficits such as dementia and abruptly relocate them even to a new nursing home, or during COVID when they couldn't get out of their rooms, for example, in facilities, unfamiliar environment may lead to confusion and exacerbation of pre-existing cognitive deficits. But there are also studies of cognitively intact people, older adults, living in the community that were temporarily relocated after the earthquake and tsunami in Japan. And you probably remember there was a nuclear disaster also associated with that. Followed up for up to 5 years, there was a significant increase in the percentage of cognitively impaired people. So I depicted it as this vicious cycle, if you want. So people with cognitive deficits, first of all, they may be unable to flee for all the reasons we discussed. If they do get out, they may have to be forcefully relocated, which can increase their cognitive decline rate, which can actually further lead to social isolation, which is a well-known factor contributing to cognitive deficits, also well studied. Very interesting epidemiological studies show air pollution connection to cognitive decline. And I looked this up because I was curious. Actually, air pollution was recently listed as a risk factor for dementia by the Lancet Commission in 2020. And we have numerous studies, but to cite just a few, adults in the Metro Atlanta area from an Emory study, people over 50, living in neighborhoods with low socioeconomic status, most vulnerable to air pollution. So you see here social determinants of health in action. But then two very interesting French studies, both were from France. One was a prospective cohort following older adults, median age was 74, followed for up to 12 years, and they show that the higher the exposure to particulate matter with diameter higher than 2.5, so we call this PM 2.5, the main air pollutant that is being studied, associated with cognitive decline over time. And then in a cross-sectional study, way larger cross-sectional study, the exposure to black carbon, nitrogen dioxide, and PM 2.5, again associated with significantly poorer cognitive performance over time.
2 minutes, Andrea.
Perfect timing. Air pollution also associated with depression. And then I just want to share with you the social determinants of health in this particular diagram, which you are very well familiar with, but I juxtaposed over these where I think climate change related factors are actually interspersed and can cause more problems. So first of all, we talked about low health literacy, not having access to the internet, linguistic isolation. People can get out of harm's way with natural disasters or heat waves. Food insecurity, actually, Dr. Weiser is a worldwide expert in food, the intersection of food insecurity and climate change. And I hope you can look up her research also. Climate refugees, people who have to leave their homes because they can no longer make a living or their homes were disrupted. Think about disasters disrupting communities, displacing people, and think about indigenous cultures. Their cultures are related to their cultural traditions and customs are related to being on the land, being able to be in nature, and that is obviously very disruptive for them if they can't access nature. We talked about infrastructure disrupted by natural disasters, and uninsured families goes without saying. We're going to hear in a moment about hopefully redlining and urban heat islands, but then also neighborhood level pollution. I talked a little bit about that. So I want to leave you with this take-home message. Start thinking now, from now on, for those of us who are healthcare providers or public health experts, when you think social determinants of health, please also include ecological determinants of health, access to green and blue space, access to nature, walkability, neighborhood walkability, access to cooling centers during heat waves. Those are also very important determinants of health that we must start to pay attention. And I would be remiss if I didn't mention resilience. We talked about all the risk factors for older adults, but older adults are very resilient. One of the incredible aspects and rewarding aspects of my work as a geriatric psychiatrist, older adults often lead in rebuilding the communities that were destroyed by natural disasters or other disasters or war. help maintain the coherent sense of identity for their families and communities. This has been very well studied. Social capital, social support, and social cohesion in the communities actually well studied as a resilience-inducing factor, individual for older adults, as well as communities recovering from natural disasters. Life experience, particularly previous disaster experience, including, sadly, human caused terrorist attacks. So 9/11, people who went through 9/11 and then they were exposed to Sandy, to Hurricane Sandy, they actually did a little bit better because they had previous disaster experience. Optimism, spirituality, and other factors. Older adults are very resilient, even though they suffer a lot. And with this, I'm just gonna let my colleagues talk more. And thank you so much. And hopefully there will be some questions for me. I'm gonna stop sharing. Thank you.
Hi, if we are just supposed to switch to our presentation, maybe I'll ask Kato to share the slides that she's prepared. So hello, everybody. Again, Eddie On, Executive Director of Brightline Defense, working today with Kato Correa, who works on a series of air quality monitoring programs and other tenant empowerment programs ongoing at our 501c3 nonprofit. So for those of you coming to learn about Brightline for the first time, we're a 501c3 nonprofit based in San Francisco. And the next slide will show perhaps the kind of a broader scope of our work and maybe show even our staff and how we're inspired to continue working in community to begin with. The way I often describe our nonprofit is essentially two different types of work. One is in direct services, the act of providing services directly to the community. So it could be something like a job training program, a series of youth leadership programs in parks and open spaces and cooling centers. Also embedded in our work is a significant amount of air quality monitoring programs, which you can see in the top left photo, a photo of Kato working on one of our outdoor air quality monitors. But we also work on indoor air quality monitoring, which we'll cover later on. And a lot of this work ends up informing our work in policy as well. So myself and a policy team, we often toggle back and forth between hyperlocal jurisdictions as well as state capitals to hopefully create, ongoing good policy in clean energy, something as ambitious as offshore wind, for instance, in the bottom right corner. Today, we'll talk a bit about our work in building decarbonization, which is around energy efficiency. And with that, I'll transition it perhaps to Kato on the next slide to start describing the communities that we directly serve at Brightline.
Yeah, absolutely. Hi, everyone. Kato here, she, her pronouns. So I'm going to talk a bit about the communities we serve at Brightline, and then pass it off to Eddie to talk a bit about SROs and the decarb work that we do. So a little bit about the communities we serve. Here's our priority populations map of 2023. If you'll see, I don't know if you can see my pointer, but on the top right side of this map, you'll see purple, green, and some like lines that are gray. That's generally the area that we serve. So this is the communities in Eastern San Francisco, the communities of the Tenderloin, Chinatown, Soma, and then a bit of work done in Bayview Hunters Point as well. These are communities that are designated as disadvantaged and low income because of a number of environmental justice issues, one of them being air quality. So we've really focused our programming around these communities and really want to spotlight some of their concerns today. One of these communities and like the community org they want to spotlight today is Central City SRO Collaborative. This is our community partner across several of our air quality programming work. So Eddie's going to talk a bit more about what SROs are, but essentially it stands for single room occupancy hotels. These are like an older building stock that really require a lot of resources. And so with Central City SRO, or CCSROC, we have a tenant leadership program. So we have a picture on the bottom of our tenant leaders. We have about 10, and about 70% of them, I would say, are folks older than 60, or 60 and older. And so these are folks that are heavily impacted by poor air quality in the region, in the Tenderloin specifically. A bit more info on this is in 2021, we interviewed about 255 tenants in SROs, and a good majority of the folks reported being very low income and also elderly and non-mobile, so not being able to really leave their apartment or their unit. They also reported 57.9% of SRO residents reported having chronic health conditions or a physical health condition. And the most reported health condition was asthma with 32.7%, hypertension following that with 13.1%, COPD 9.5%, diabetes. And these are health concerns that are definitely exacerbated by poor air quality and extreme weather events like wildfires and heat waves. So I'll pass it to Eddie to talk a bit more about SRO conditions and a bit about our decarb work.
So Kara already gave you a bit about the demographics from the survey that Brightline conducted back in 2020, 2021, and that link is pasted into the chat. But, maybe first of all, dwelling on two things. One, the conditions, the historical conditions of these buildings, and then two, a bit more about why SROs even to begin with. So the historical conditions of these buildings, keep in mind these buildings were built in the 1900s with a very different intent. SROs were very common in major American cities. In that period, they were meant to essentially house a temporary workforce. It could be secretarial, it could be farm workers looking to stay in the city, but essentially different kinds of working populations were supposed to stay temporarily in this housing, which is why they have common facilities like shared bathrooms, shared kitchens, and the rooms themselves are really small to begin with. San Francisco has chosen to maintain its SRO housing stock as essentially a form of low income to very low income housing. And part of that has led to the building, like there's essentially a diverging kind of stock even based on who owns it. So oftentimes privately owned SROs, for instance, are not as well maintained as SROs that may be maintained by, say, nonprofit corporations. The reasons for that are numerous, but the gist is these buildings are quite old and they don't have modern HVAC systems. They're quite cramped in terms of conditions. And as a result, if you think through the populations that live in these buildings too, like it can be either SRO families, so an entire family of 4 can live in something like 80 square feet. And on this slide here, you'll see pictures of a Chinatown SRO where that's quite common for immigrant families. The other type of population that Kara mentioned was essentially an elderly population. And oftentimes it's seen as like a housing of last resort or their final housing unit before they pass on too. So just keeping in mind the conditions of these buildings themselves are very tough, as well as the actual kind of conditions that they grew up in are difficult as well. In the next slide, we'll show perhaps Brightline's connection in policy and trying to improve the conditions of these buildings. So here you see essentially investigations of SROs to begin with, and this is of on the left, a particular SRO in Chinatown operated by Chinatown Community Development Center, CCDC. It's a partner of Brightlines that does a lot of great work throughout the community, and they own assets and essentially invest resources to maintain them. And nowadays, Brightline is working with a larger coalition of affordable housing developers like CCDC to essentially try to get them connected to IRA funding to improve the conditions of these buildings, to do things like rehab work, better insulation. It could be light touch energy efficiency measures such as weather stripping, but the bigger ambition is really kind of modernizing these buildings so that they're not as leaky, for instance, or can be, or they're not as permeable during, say, a bad wildfire smoke scenario. In the middle is the California Air Resources Board Chair, Leanne Randolph, who has also come to investigate conditions of housing and residents in Chinatown, for instance. And then on the right-hand side shows perhaps some of the media efforts that come with our work. And then as well as in the bottom right, you'll see a do-it-yourself kind of air filtration unit back in the day where we were piloting as a workshop. And nowadays, that kind of air quality filtration work has increased in sophistication, as Kara will describe later. But yeah, it's ongoing work. We hope we can't move quickly enough, but part of it, the realization is like federal money moves slow too, and that it needs to be issued in a very particular way. So a lot of Brightline's work is just trying to figure out where that rubber will hit the road, so to speak. And then the next slide, I think, is back to Kato talking about working across languages.
Yes, thanks, Eddie. I wanted to touch a bit on how we're doing some of this work. We're doing it across several workshops across these neighborhoods that I touched on, and it's across several languages. So we work with folks that are just Spanish speaking monolingual communities, with La Voz Latina, for instance. We also work with folks that are Chinese speaking, so that's Cantonese and Mandarin speaking communities, with CYC, so youth, as well as the elderly, as you can see in that bottom left picture as well. And we try to give out these resources, but I'm gonna dive a bit more into kind of like the nexus or the reason why we started developing more of these air quality programs, and then we'll dive into some of the interventions that Brightline takes. So disproportionate impacts across San Francisco. You'll see on the left-hand side here a map of purple air monitors. So this is during a particularly bad like wildfire event. So you'll notice that the red and the orange purple air monitors are on the more the eastern side of San Francisco versus the west side, still having moderate air quality, but it's really concentrated on the east. And you'll notice a gap on the eastern side that wasn't really like covered during the spread of purple air monitors. And so that's really the neighborhoods that we wanted to deploy some monitors in to try to understand what's like the more local impact of poor air quality in San Francisco. And you'll see that in our map on the right-hand side. This is a map of a couple of clarity sensors that are deployed across Soma, the Tenderloin, and Chinatown, all the way down to Potrero Hill. So I'm going to touch a bit on some like health impacts of air pollution, specifically wildfires, before jumping into our 3 different programs we'll talk about today. So on a regular day with poor air quality, let's say, not really like a wildfire event, there are lots of pollutants like PM 2.5 and nitrogen dioxide that have impacts over time on our bodies and our health, including something like reduced lung capacity, asthma, increase in asthma symptoms. But wildfire impacts are particularly bad. These are wildfire pollution peaks that can be up to 10 times as harmful to human respiratory health. So that's why we really, really wanted to emphasize SRO conditions and resources focused into Eastern San Francisco. And here's some immediate health impacts I wanted to highlight, such as coughing, sore throats, itchy, watery eyes, headaches, and fatigue that come out of that. But also long-term effects such as inflammation, oxidative stress, which can lead to larger problems like arthritis, cancer, and diabetes in folks, as well as like infection in bloodstreams and buildup of damaging cells. So that's really, really bad, especially when we think about SROs and the indoor air quality conditions that elderly folks and folks just living in SROs are living through. So I'm going to preface a bit our air quality programs and then pass it off to Eddie to talk a bit about our first one. So our Brightline Air Quality Monitoring Program was kind of born out of this need for resources in the east side of San Francisco. This is our technical program with the monitors. Then we have an indoor air quality study, which is Follow the Smoke, which I'll be touching on. And then finally our community, our air program. So I'm going to pass it off to Eddie to speak a little bit about our first program.
I feel like we should skim ahead. The next slide will show a few photos of essentially our air quality siting that we've done. We often work in collaboration with academic institutions like UC Berkeley's Lawrence Berkeley National Labs, Dr. Chelsea Preble in particular, as well as the Bay Area Air Quality Management District, which has devices such as that top right corner device you can see called essentially a sensor verification system. It's like maybe the more colloquial way of putting it is it's like a super device that helps calibrate our ongoing external air quality sensors. And the company that we have used quite a bit is Clarity, based also in Berkeley. And they have a number of projects across the world in collaboration with city governments, actually. But I'll switch it back to Kato to try to wrap things up. I see that we're running out of time. So Kato, do your best perhaps in the next minute so we can allow for some questions from the audience.
Of course, yes, I'll breeze through these. So I just wanted to show some high level like takeaways of the Follow the Smoke study that we did in SRO units. So these were 20 indoor sensors that we distributed across 3 SRO buildings, just trying to understand what indoor air quality is like baseline and also what it could be during a wildfire event. Luckily, there was no wildfire during this period, so we didn't really get huge stats on wildfires, but we did get an understanding of how bad the indoor air quality is in some of these SRO units. So here's a quick graphic. 50% of the SROs in our study had indoor air quality that was deemed unhealthy or worse. That's especially bad when we think about the amount of time that folks are spending inside SROs. I think I mentioned some folks are non-mobile in SROs, so they're essentially just breathing in poor air quality all day. And then how much outdoor PM 2.5 particulate matter is coming into SRO units. We found that on average, 55% of outdoor PM entered the rooms. That's particularly bad when we think about wildfires also, and the increased impacts on health that wildfire smoke has. And finally, our community, our air program, I'm gonna breeze through this. This is our program with the Air District, where we try to increase capacity, community capacity, and participation in air quality decision-making processes, such as like giving public comment, learning who to call when there's a restaurant right underneath your building, putting smoke in your room, stuff like that. So we go out and give trainings to folks, talk about air quality, talk about resources they could tap into. And so here's us talking to CYC Baby Hunters Point group, a group of elderly folk out in Baby Hunters Point. And then on the right, it's our SRO tenants playing a game about air quality conditions in the city. And finally, just to wrap it up, something we've been really fortunate to do is some community air purification distributions. This is a great example of our leaders learning the public comment process and being able to take the air quality information from our monitors and go and advocate for more resources in SROs and across the Tenderloin. And as a direct result of that advocacy, we were able to secure some funding to have our leaders design and distribute air purifiers across the Tenderloin. And so they were giving, they're doing house deliveries. As you can see, our leaders have like a little cart so to go up and downstairs in the SRO units and deliver these to folks that reported having a health concern around air quality. And 90% of folks reported having an improvement in health symptoms and overall indoor air quality. So we're going to continue to do this work and continue to advocate for more resources in the east side of San Francisco. But if y'all have any questions, feel free to ask us. But that's it.
Okay. Thank you very much to the 3 speakers for the excellent presentation and to be more or less on time. I think we are good. So now we have some time for discussions and questions for the speakers. And I will just like start by summarizing some of the questions that have been already put on a box, and also remind to the audience, if you have any question, you can use the Q&A box. So there is a question that has been asked, which I think is related to what Carol just talked about the effectiveness. This is a question by Elina Selemon that I will just rephrase and reframe a little bit, but this is really about just like effectiveness of the actions that you're experimenting. So just a question would be about what do you think, and you reported at the end like 90% of the participants reported like an improvement in health symptoms. And I wonder what in general, how do you evaluate your programs, and what do you think about the mechanism that may explain the potential benefits and potential positive aspects of your program. So just like what do you do to try to evaluate the effectiveness of your program in general? So that's a question first for Eddie and Carol, and then there will be a question that will be more for Dr. Sheridan. So Eddie, Carol, who would like to take this one?
I'll kick us off. That's okay. So if the question is like, what are some examples or ways that we've measured success across our programs? I think a really big one, and the one that I like to talk about, is how our community leaders feel. If they feel fulfilled in their advocacy work, I think that's first and foremost. And then the second one being I've been really like privileged and excited to be a part of the air purifier distributions. So I'll say we monitor like baseline understanding of what air quality was, indoor air quality was, before doing an intervention. So in the case of air purification, what we did was we did like an intake survey with folks that self-reported having respiratory illness issues or symptoms. And so they reported what they were feeling, such as like headaches, migraines, watery eyes, etc. Then we gave them the air purifiers and then called them up 2 weeks and then a month later. And they reported, like 90% of them reported seeing a difference, especially like as we think about SROs and we think about the different conditions folks live in. A good example I have is our levelist leader, one of our levelist leaders shared that she has asthma and actually lives next to somebody who smokes pretty heavily, and her asthma symptoms like have decreased immensely. So I think that's a huge win. Eddie, did you have anything to add?
No, I'll let that answer stand. That was really great.
Okay, thank you so much. And there are a few questions, and thank you to the audience for your questions. I would just maybe like switch to a question for Dr. Sheridan about just like the education of clinicians. And I think your presentation was great in this regard because you really are the interface between clinical practice and like research and epidemiological research in this area. So the question by Deb Simpson is really about how, could you describe some effective strategy to educate clinicians? And initial training, but also continuum training. I think that would be interesting for the audience to discuss about the specific topics.
Yeah, great question. Thank you so much, Deb. And also, I think there was a question about resilience that I can answer. So I think that question actually can very well be answered by Eddie and Carol as well. But from our point of view, so from my point of view, obviously I sit in the ivory tower here in academia, and we try very hard to go out and give talks in the community if we can, traveling around the country virtually to decrease our carbon footprint, giving talks. So I would be happy if you email me. I can put my email address in the chat. We would be happy to talk more about, education for clinicians. Two other very quick resources. The Climate Psychiatry Alliance, CPA, Climate Psychiatry Alliance, they have developed some very simple brochures, pamphlets that you can take if you're a clinician. So they're for clinicians and then also for patients and families on how to deal with extreme heat, how to get prepared, emergency preparedness. So you can find them on their website. I'll see if I can find the link quickly during the Q&A session. And then what else? Multiple, there are many other resources out there. I will just mention one that was very helpful to me and actually was mentioned in one of my slides. The Yale School of Public Health has an amazing course on climate health and climate change and health, I think it's called. Again, if you email me, I'm happy to share the link. It's not free, but it was absolutely worth investing if you're an educator. So to summarize, train the trainers, create a ripple effect as much as possible. Go to the source. I always use sources that are verified and evidence. Don't ever say anything that doesn't have at least one piece of evidence supporting it, because this is very important. We need to maintain our credibility.
Thank you so much.
I'll see if Eddie and Carol, do you want to add anything?
Very good. That's perfect. And thank you for your answer to that. And actually, there was a very interesting question that would be mostly for Caro and Eddie about the unintended consequences of this program, and one, especially on the energy cost associated with, like, for example, the use of air purifiers and other strategies that you may think. And another obvious one is about the use of air conditioning. And there is a lot of literature showing how even when people have access to air conditioning, they may not start using it before it's too late because of some energy cost concerns. So that's a question from, Michaela White. And I think this is a very good point about the potential unintended consequences in terms of, in relation to energy justice issues. So if you want to comment on that, either Eddie or Caro or both.
I can try taking a stab at it. So we do a significant amount of work around clean energy advocacy. Nowadays, our efforts have focused on something called offshore wind, which is about wind turbines essentially on the ocean, trying to gain equity for local communities that may be impacted by offshore wind development too. But there's a larger kind of energy justice vision behind it, which is making sure we are not reliant at the end of the day on fossil fuel power plant, peaker power plants as they're known across the state. That's an ongoing issue in California where we want to believe that we are moving toward clean energy, but management of that grid it has been really difficult to do. And then the other kind of equity-oriented issue is just making sure that rates aren't also surging for households as well. So currently, there's a lot of factors tied to rates to begin with. So wildfires alone and undergrounding of transmission cables, for instance, have increased costs. So there's a lot wrapped up in it. We could probably spend an hour talking about it, but I think at the end of the day, like we'd want to make sure that AC is connected to clean energy generation, and that's a lot of our advocacy. And then there are other components, of course, too, battery storage and management of a clean grid.
And about the costs associated with the use of these technologies?
Yeah, that's an ongoing set of issues. I think it varies widely state by state too, depending how they distribute the costs of energy grid management, transmission lines, etc. So I can speak a bit more to California, but the gist is like it's going to need a lot of government investment at the end of the day. And I think the good news is you're starting to see that flow out of particularly things like IRA funds.
Yeah. Caro?
I could add really quickly for like a more micro level like example with SROs and purification. We chatted with the SRO tenant leaders who did have concerns around like electricity and having too many things plugged into their outlets. So some of the solutions we took there was number one, like picking an air purifier that was like lower in terms of like amps that it needed or like electricity it needed. And then also helping folks by going into their units if they consented and helping them like set it up so it was safe and didn't like cause any issues, any like fire hazard, anything like that. And the other thing is, I believe SRO tenants, some of them are on a program that actually reduces or like puts all of their bills together. So it wouldn't be so much of an electricity like burden on them to have that purification.
One other quick note is like what I'm gleaning from the question too is none of these issues work totally siloed. In other words, they are very connected with each other. And one other thing to realize perhaps is energy efficiency can also lead to things like not putting the AC on full blast all the time. Ideally, a room, in other words, is well insulated enough where not cranking down the thermostat every time you feel like a heat wave's coming would be really good too. So in other words, there are a lot of other measures, in other words, to ensure that we aren't using things like AC or whatever it may be on full blast.
Thank you so much. And just a follow-up questions about just like how the specific programs that you're implementing as part of Brightline, but also as in terms of your clinical practice. Dr. Sheridan, about do you know if, or to which extent, like the communities or the patients you're working with are aware of existing strategies and programs, such as, for example, in the context of a heat action plan, access to cooling centers, or do they know what to do when there is a heat warning system or a smoke warning system, and to which extent they are aware of existing programs like access to cooling center, but also like clean air center, like kind of rooms and centers that are being experimented in California. Is it something that you think the population you're working with are aware of, or if not, which is like a kind of between the lines in my question, what could we do about that? Both at the kind of community level, but also in a kind of clinical healthcare sector. So that's a question for the three of you. I guess, do you want to start, Eddie? Just
Yeah, I'll take an initial stab at it.
Yeah.
So I think the basic premise is there's a challenge at the end of the day in terms of educating the community. You can build a clean air center or a cooling center, but at the end of the day, people may not come to. And that's something that in San Francisco, hyperlocally, we've been grappling with. I think it's easier to start with local public institutions that are known, such as like a public library branch, for instance, or maybe a community center that or senior center that's particularly well known. But yeah, you know, you can build it. In other words, you can invest a ton of resources, but then educating the community to go walk over, even in a dense urban area like San Francisco, has been a challenge. I don't know if there are other observations. And then you can only imagine that challenge multiplying if you're, say, operating in suburbs or more spread out geographic areas too.
Yeah, in terms of access, transportation, etc. Carol, Andrea, would you like to react to these issues? Andrea already reacted on a chat saying that, yeah, just in the same vein, saying that there is, yeah, people need to be aware of that. And there is also something about access, and there is a lot of issues that have been documented in the literature in terms of, for example, unhoused individuals or individuals experiencing homelessness, and how there are a lot of challenges to get access to this cooling center in libraries or public spaces in general. And also about, I don't know if some of you are already experienced what it is, a cooling center, but that's extremely not appealing. This is extremely boring. You go, this is basically like a room with like air conditioning, but just like plastic chairs and nothing else. And I think there is a huge, a huge amount of effort that we can do and eventually combine that with access to social services, mental health services, etc. So I think there is a huge opportunity for cooling centers to be a place for like to reach out to the most vulnerable communities. And I think that's probably part of the next step to try to combine these existing efforts. And as I see Sherry appearing, I think this is probably some time to wrap up. So we'll have hopefully, I see there are like 2 questions for Dr. Sheridan that you can probably answer directly on the chat, but if that's okay, and I will give the mic virtual to Sherry to wrap it up.
We have time for 1 minute quick response.
Can I answer the resilience one? Will it be okay? I promised I would answer it live.
Sure. Just to make sure, just to wrap up this specific part of the question, Carol, would you like to add something about the cooling centers and thing, and also Andrea, and then we can maybe discuss the resilience, just to make sure we close this part. Is that okay? Carol, nothing to add? Andrea, nothing to add on the cooling center? Okay.
No,
so yeah, so maybe
nothing
if you want to
on
comment on resilience, go ahead.
Yeah, thank you so much. So thank you for all the questions. If you have any particular questions for me, feel free to email me. This was such a rich discussion in the Q&A. For resilience, I would say, and I think the question came from a colleague from Uganda. Thank you so much for thinking of that and looking at that. Social support and social cohesion for communities is very important and actually was contributing to resilience in many studies. If there's anything you can do for community organizing. And then there's also a study from the United States looking at volunteers. So people who are educated to a course learned how to do little projects in their communities to help mitigate climate change. And then they were actually doing so much better, also increase their well-being, but help the community. So anyway, long discussion. We could talk a lot more. But I know we have to go. Thank you so much. I learned a lot from Eddie and Caro and all the questions asked.
Wonderful. Well, thank you so much, Dr. Saratin, Ben Marnia, Mr. N, and Korea for your insights today. And thank you for the audience for your questions and interest in the topic. I also wanted to shout out to Liza Hayes for amazing help in setting up and organizing all of these webinars. We look forward to sharing the recording with registrants, and thank you very much. Take care and have a nice day.